day, and welcome to Epstein Becker Green's webinar, Mental Health Parity Implementation. Are we there yet? Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions directly to the presenter following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have a fantastic speaker today. Epstein Becker Green's Lesley Yeung is an associate in the Healthcare and Life Sciences practice in the firm's Washington, D.C. office. At this time, I'd like to turn the webinar over to Lesley.
Thank you. So I think it's safe to start off by saying that the answer to the question, are we there yet, is no. In the short time that we have today, I'd like to talk about how legislators and regulators have grappled with the concept of mental health parity, what the current enforcement environment looks like, and what may be on the horizon. To start off, the concept of mental health parity is fairly simple. Insurers should provide the same coverage benefits for mental health and substance use disordered treatments as they do for medical and surgical treatments. And this comes down to the belief that treatment for mental illness is as important as treatment of physical conditions. On the next slide, we see that this journey towards mental health parity really began back in 1996, now 20 years ago, with the passage of the Mental Health Parity Act. The Mental Health Parity Act prohibited large employer-sponsored group health plans from imposing higher annual or lifetime dollar limits on mental health benefits than those applicable to medical and surgical benefits. However, I think the belief was that that didn't go far enough. So in 2008, the Mental Health Parity and Addiction Equity Act, or MAPIA, expanded the scope of mental health parity requirements further. So parity requirements applicable to both self-insured and fully insured large group plans covering 50 or more employees were expanded to include substance use disorder treatment benefits, as well as all financial requirements such as co-pays and deductibles, quantitative treatment limitations such as visit limits, and non-quantitative treatment limitations such as prior authorization. Importantly, MAPIA does not require coverage of mental health or substance use disorder benefits. However, if a plan chooses to offer such benefits, the plan must comply with MAPIA's parity provisions. In 2010, the Affordable Care Act did mandate that mental health and substance use disorder treatment services be provided as part of the essential health benefits package offered by certain plans, those being individual, small group, and Medicaid non-managed care alternative benefit plans. And those are plans that states may offer to Medicaid expansion populations. Accordingly, all of these plans that are required to cover the essential health benefits must do so in compliance with MAPIA. On the next slide, we will talk about the slow process for adopting mental health parity regulations over the past almost decade now. In February 2010, 2 years after passage of MAPIA, the Departments of Health and Human Services, Labor, and Treasury issued interim final regulations implementing the mental health parity requirements in MAPIA. It then took the departments another 3 years and 9 months to issue final regulations, which they did in November 2013. The final regulations establish a framework for plans and issuers to determine parity among benefits. While there's a lot to absorb within those regulations, I'm just going to highlight a few points right now. Namely, financial requirements and treatment limitations applied to mental health and substance use disorder benefits must be no more restrictive than the predominant type of financial requirements or treatment limitations applied to substantially all medical and surgical benefits in the same classification. In this context, the departments determined that predominant means more than half and substantially all means 2/3. So that's quite a wordy requirement, which sort of makes my head spin. But to break it down with an example, If a plan wants to set an annual limit of 20 outpatient office visits, that's permissible if that type of limit applies to at least 2/3 of outpatient office visits on the medical and surgical side, and if more than half of outpatient office visits on the medical and surgical side are limited to 20 days. The 6 benefit classifications that are referenced in the regulations include in-network inpatient, out-of-network inpatient, in-network outpatient, out-of-network outpatient, emergency care, and prescription drugs. Further, plans are required to make available upon request the medical necessity criteria used to make coverage determinations about mental health and substance use disorder benefits, and they have to provide reasons for any denial of payment for mental health and substance use disorder services to plan members who request that information. On the next slide, I'm going to talk a little bit further about the regulations. The effective date of the final regulations was for plan years beginning on or after July 1, 2014, which for most plans meant that implementation really only started on January 1, 2015. So we have about a little over a year of experience of implementation of the final regulations. In 2013, HHS reported that health plans subject to MAPIA had the lowest rates of compliance with respect to non-quantitative treatment limitations. And so it should probably be no surprise that implementation issues related to NQTLs still continue. Some particular challenges that we've heard about are developing medical management standards, limiting the scope or duration of treatment that are comparable to and applied no more stringently than those imposed with respect to medical and surgical benefits, applying comparable and no more stringent factors related to provider reimbursement for both mental health and substance use disorder services and medical and surgical services, and then determining standards for provider participation in a plan's network, which such a determination can actually be further implicated by state licensure and scope of practice requirements, as well as the provider non-discrimination requirements included in the Affordable Care Act. There are other concerns as well, not just NQTLs. These other areas relate to the requirement that financial and quantitative treatment limitations, so for an example, an annual deductible amount, cannot accumulate separately for mental health and substance use disorder benefits and medical surgical benefits, which is particularly challenging when mental health and substance use disorder benefits have been carved out from the health plan. Also, intermediate services such as skilled nursing and home health on the medical surgical side must be classified the same way as mental health and substance use disorder intermediate services across the 6 benefit classifications. So, for example, if skilled nursing is considered an inpatient benefit, so should residential treatment facility services. The concern is that some treatments for mental health and substance use disorders do not have medical and surgical benefit equivalents. So, for example, intensive outpatient programs used to treat mental health and substance use disorders don't generally have an equivalent on the medical side, and so it's difficult to determine how to make sure that they're being classified the same and covered the same way. On the next slide, so far, we've been focusing on the commercial sector, but it is important to note that various statutes have applied mental health parity to Medicaid managed care plans. However, CMS did not release a proposed rule implementing mental health parity requirements for Medicaid and CHIP plans until April of last year. The proposed rule that did come out last year generally aligns with the approach that was taken in the final regulations for commercial plans issued in 2013, so that there would be consistency between the commercial and Medicaid markets. Importantly, the proposed rule did clarify that mental health parity requirements apply to all beneficiaries receiving any services through MCOs, ABPs, or CHIP, regardless of whether those services are actually provided through another service delivery system. So, for example, there are instances where fee-for-service or managed care carve-outs might be supplying mental health benefits under a Medicaid managed care plan. The finalized provisions will take effect 18 months from the date of publication of the final rule, which we're expecting probably in April, so imminently. Next slide. In the time remaining, I'd like to talk a little bit about enforcement. Not only are the rules themselves complicated, but even the enforcement of mental health parity requirements is tricky to understand. Enforcement authority is split between the states and the federal government, so there's a couple of things to understand here. Most states have their own mental health parity laws, which are not preempted if they are more restrictive than the requirements in the PIA. So states can take enforcement action regarding their own state laws. But in addition, the state departments of insurance have primary authority with respect to fully insured group health plans and plans sold in the individual market. Further, federal enforcement is split between the Departments of Health, Labor, and Treasury, depending on the type of health plan at issue. You'll see here that HHS's enforcement authority overlaps with the state's authority, and HHS can act if it determines that a state is not substantially enforcing the law. On the next slide, I have included a few examples here of some of the limited enforcement actions that have been taken by states, particularly when those states have their own mental health parity laws. New York is a good example of active state enforcement. The Attorney General has investigated a number of plans and reached 5 settlements since the beginning of 2014. The Attorney General really looked at the services that were being provided and the issuance of claim denials for mental health or substance use disorder services, and made a determination that if the percentage of denials is higher for mental health and substance use disorder services, that may be evidence that there's a violation of an NQTL parity requirement. Since state enforcement has been somewhat limited, it is likely that we'll continue to see increased attempts to enforce the mental health parity requirements through private suits brought against health plans. To date, we have seen advocacy organizations partnering with patients and providers to bring class action suits to address various plan administration concerns, such as disparate application of algorithms, prior authorization rules, concurrent review policies to mental health and substance use disorder claims, as well as blanket exclusions of certain types of services or services received at certain types of facilities. The residential treatment facilities is an example that comes up frequently. And we expect that these types of private actions are likely to continue, especially until state or federal enforcement action really picks up. Finally, on the next slide, I have a couple of examples here of what seems to be on the horizon. So there are a number of bills that have been introduced recently to continue to shape the mental health landscape and further strengthen mental health parity requirements. Bipartisan support seems to exist for addressing concerns with the mental health care system, but there are contentious issues around how best to achieve these goals. Some common themes seem to be addressing the permitted health information disclosures under HIPAA, an area that has been a concern for a while, encouraging integration of primary and behavioral health care, as well as addressing some concerns around mental health parity implementation, such as really delineating what a plan's disclosure requirements are and what state and federal enforcement requirements are. And some of the areas that have been more contentious is how to cover IMDs under the Medicaid program and whether funding for the SAMHSA program should be refined or changed, if there should be a different layer of authority created at the Department of Health and Human Services to address mental health services. So there's a lot on the horizon that we expect a lot of discussion of mental health parity and mental health generally on the Hill in the next coming months. And with that, that concludes the brief tour of our discussion about mental health parity, and indeed it is It is an ongoing process and journey.
Thank you, Lesley. Thank you for speaking today, and thank you to everyone for joining us. You are welcome to submit questions directly to Lesley following the webinar at lyeung@ebglaw.com. That is LYEUNG@ebglaw.com. And we hope that you'll join us for our upcoming webinars, such as our March 29th crash course session, which is the last in this series, on managed care and behavioral health. For additional details or to watch recordings of previous sessions, you can visit www.ebglaw.com/events. And this concludes today's webinar. And approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you.